Today we are looking at a paper that just came out in the journal Gut, and it is causing a lot of noise online for good reason. The headline is that a model called REDMOD can detect pancreatic cancer signal on CT scans that radiologists already read as completely normal with a median lead time of around 16 months before clinical diagnosis. The social media version of this story is that AI can detect cancer 3 years early. That framing is not quite right. What is actually happening is more interesting, and today we want to walk you through what the science actually says. First, some context on why pancreatic cancer is so brutal. The American Cancer Society projects around 60,430 new U.S. diagnoses in 2026 and about 51,750 deaths in the same year. 5-year survival is around 13% overall, but that number hides a huge range. Catch the disease when it is still localized and surgically removable, and 5-year survival can run above 30 to 40% with modern chemotherapy. Catch it at stage 4 and you are looking at closer to 3%. The entire problem is that roughly 85% of cases are caught only after the cancer has already spread. By then, surgery is not on the table. The disease is invisible during the only window when medicine can actually cure it. So what is REDMOD doing? This is point 1. REDMOD is not a tumor detector. There are no visible tumors in the scans it is analyzing. A competent radiologist already looked at those scans and said they were normal. What REDMOD is doing is picking up subtle tissue changes in the pancreas, texture patterns, volume shifts, ductal caliber drift, things that are too low amplitude for a human reader to consistently catch. These are imaging fingerprints of pre-neoplastic biology, cellular changes that can precede a detectable mass by a year or more. Sensitivity in the validation cohort was 73%, specificity was 88%, and test-retest agreement on repeat scans was 90 to 92%. The specialist comparison on the same scans came in at 39%. Point 2. The data behind this model matters as much as the model itself. The team is Mayo Clinic plus MD Anderson. They validated across multiple institutions, multiple scanner manufacturers, and multiple imaging protocols. A model that only works on one scanner at one academic center is a paper, not a product. The fact that REDMOD held up across vendor and protocol heterogeneity is what makes it worth taking seriously as potential deployable infrastructure. The asset is not just the algorithm. It is the paired imaging plus future cancer outcomes dataset that no one else has assembled at this scale and quality. Point 3. There is a prospective trial now running called AI PASTE, which stands for Artificial Intelligence for Pancreatic Cancer Early Detection. The 73% sensitivity number is retrospective. That means the cases were selected because those patients eventually got diagnosed, which flatters the model in ways that prospective, real-world deployment will not. AI PASTE is enrolling patients at elevated risk, running REDMOD prospectively, and tracking forward. Those prospective numbers will be the ones that actually matter for regulatory clearance, reimbursement, and clinical adoption. Until then, the headline should be read as a ceiling, not a guarantee. We are just scratching the surface here. Part 2 gets into the screening math, the Bayesian problem that has killed every prior attempt at population-level pancreatic cancer screening, the enriched cohorts where this model might actually be economically viable, and what the multimodal future of risk inference looks like when imaging combines with liquid biopsy and EHR signals. That analysis is in the full article and in the paid podcast episode. Subscribe to On Healthcare for Part 2 and the full analysis, link below.